So, good afternoon, good morning, everyone, and I'll be talking about corneal procedures, indication and consideration. I think we have seen all the surgeries in detail, and we all know that how to perform these procedures. So, we'll be talking about some of the preoperative decision-making, counseling of the patient, expectation, and when not to do procedures, and how to choose these procedures. So, straightforward, we are going to the selection criteria for laser procedures because this is the most toughest job for the LASIK surgeon or refractive surgeon, how to decide whether we should go for surgery or not. So some of the basic criteria by which you can screen the patient in your optometry room only. For example, if the individual is less than 18 years, there is no point of getting the examination done also. Just straightforward, give glasses and send the patient off. So refraction has to be stable for at least 1 year. If some patient is of age of above 25, you can still consider lesser duration, maybe 6 months or 9 months, that is good enough. But younger the patient, you have to wait more to become stable. Again, corneal thickness, which is the cutoff of my practice, is 480 micron. I don't touch patients less than 480. If it is less than 480, it's better to go for ICL. Whether if the number is 3 or 4 diopter also, then also ICL is the preferred procedure in these cases. And absence of any significant ocular pathology. So all refractive patient has to be screened thoroughly for the entire segment examination, cornea, lens, iris, pupil size, and the most important is the retina examination. So dilated retina examination is a must. In direct ophthalmoscopy, look for the lattices and holes, and if it is there, just secure those things. Again, one more thing we have to look is amblyopia, because many of high myope patients are amblyopic. So we have to see what is the best corrected visual acuity after the refraction. You have to counsel the patient accordingly about the expectation, because if you don't tell them about the amblyopia, patient will demand 6/6 post-operatively. Then it's very difficult to defend yourself. And it's always better to note on the worksheet or in the patient's notes that he is having amblyopia and the vision will be suboptimal post-operatively. Although there is no indication that we should not do laser surgery in amblyopic patients, because I have done around 100 patients and I published a study also. And the study shows that if you operate in amblyopic eyes, vision is going to increase at least by 10% in all cases. More with the ICL, slightly lesser with the LASIK. So it will be at least BCVA or slightly more. It won't go down. So you can counsel the patient if he's happy with the BCVA preoperative and he wants just specs removal, we should go for the surgery. Because of the amblyopia, we should not cancel the procedures. And the most important is a normal pentacam or topography test. This is a must test for all the refractive surgery patient, whether ICL, whether LASIK, PRK or anything. And pentacam is the gold standard for screening these patients. So every refractive surgeon should know how to read the pentacam map. That is another important thing. So about the criteria, how much we should operate, how much number we should target in patient. So the criteria is not about the number, criteria is about the residual stromal bed, how much you are saving after the surgery. So there are different studies which tells that you should save 250, some says 275 or 300. So there are multiple studies and meta trials have been happened which have shown that if you save more than 300, your risk of ectasia goes down significantly. So we always try to save at least 300 micron in all our cases. Although there are many studies which have shown with 250 also you can get results, no ectasia, but ectasia happens in one case out of 1,000. But that one case is also big enough for us. So it's better to save maximum tissue that you can save. So with the recent concept, percentage tissue altered is another important concept. Apart from the residual stromal bed, what is the PTA value? So PTA calculation is very simple. Just use this formula, flap thickness plus ablation depth divided by CCT. For example, if you're creating a flap of 120 micron and you are doing ablation of 80, so it will be 120 plus 80, 200. For example, CCT is 500, so 200 divided by 500. So you will get PTA. If PTA value is 0.4 or more, then that's a problem. You should defer those patients for corneal brace procedures, go for the lens brace. If PTA is less than 0.4, that's a green flag. You can go for the laser procedure. So this is very simple calculation. Even your optometrist can calculate and give you the value of PTA. Once patient comes in your room, along with pentacam, tell your optometrist, calculate the PTA and write here. because they can calculate what is the ablation depth and they know what is the flap. So they can easily calculate with pentacam CCT and give you the PTA value. So decision making is very easy with this formula. So these are the topographers that are being in practice: Pentacam, OpScan, Cassini, Galilei. There are so many. We use Pentacam in our practice. So OpScan now obsolete. Very few surgeons are using now, but it's still a very good device for refractive surgery. And you have to look for the chord map. You have to look at the abnormality in the 1.5 millimeter zone and 5 millimeter zone. Oh, sorry, 3 millimeter zone and 5 millimeter zone, and you can make a decision. Although the estimation of CCT is slightly lesser in OpScan, it gives higher values. So it's better to go for the Pentacam test. So this is an example of normal Pentacam. You can see the symmetrical bow tie. All the parameters are green, 42, 43. CCT is 554, so you can correct easily. So this is another scan, which is not a normal scan. So Bellin in Pentacam map, you cannot make the decision on the basis of only 4 maps. Always go for the Bellin-Ambrosio display, because the main issue is to prevent ectasia. And this map tells whether this patient is suspicious, or this patient is going to have ectasia in future, or this patient is having ectasia or any sign of ectasia. So always look for bad scan, that is Bellin-Ambrosio, enhanced ectasia display. And if you find any yellow or red flag, always defer Corneal-based procedures. So there is a newer study which tells that if the wide to wide diameter, so this is a new concept in decision making for refractive patients. So if wide to wide is less than 11 millimeter, then you may see yellow spots in the bottom parameters or on the difference map. And if you see that DT value, if thickness of the cornea is normal and cornea is very steep, it may show that there is a yellow spot, but that cornea will be normal. So always look for the wide to wide diameter of the cornea. Smaller the diameter, it may show some signs of ectasia, but it is not ectasia, it is a normal scan. Although you cannot apply this rule on all the scans, so you have to look the patient in totality. Younger the patient, you should be more cautious. Older the patient, you may take the chance for going for the surface ablation in these cases. This is the age-old criteria of Rendelman ectasia risk factors, in which they divide the patient based on the topography pattern, whether it's symmetrical bow tie or asymmetrical bow tie. Residual stromal bed, again, as I told, more than 300, there is no risk of ectasia. Age more than 30, risk of ectasia goes down significantly. Pre-op thickness more than 510 micron, and pre-op spherical equivalent -8. So we can divide and tell the patient that in which risk category you come. So this is a newer classification in Pentacam. It's called ABCD classification, and it's based on the anterior radius of curvature, posterior curvature, thinnest specky, and distance best corrected visual acuity. And this formula will tell you whether the patient is safe to go for laser-based refractive surgery or not. Coming to the type of laser refractive surgeries, as discussed in the previous presentation, LASIK, microkeratome LASIK, femto, PRKs or surface ablation, and the newer tool is that is KLAX. So again, LASIK is a laser-assisted in situ keratomiliosis. You can get rid of glasses with this procedure. The treatment range starts from 0.5 and goes up to -10 diopters in most of the machines. While in case of hyperopia, 0.5 to 5 diopters, because if you go beyond that, it will be too flat, and there is a risk of regression also in hyperop cases. So you can club it with the cross-linking also if you are treating very high number. Astigmatism, again, 0.25 to 6 diopter cylinder. I don't treat patient less than 1 diopter because its number is very less. There is no need to treat 0.5 or 0.25 number. So the first is the microkeratome LASIK. So there are different types of microkeratome blades, and they are a very high precision oscillatory blade system, which is docked on the patient's cornea, and the lamellar flap is created. It can be nasal or superior hinge flaps. So this is one of the surgery shown here, microkeratome LASIK. So this is the nasal flap. So one, so it's always better to mark the cornea in all microkeratome LASIK. Although I don't mark, but I always advise it's better to mark, because in case of free cap or free flap, it's very difficult to locate the position or the exact location of the flap where to deposit it back. So it's better to mark on two sides so that you can correspond it and place the free flap back without inducing refractive error. So most common is femtosecond LASIK. Almost we all have shifted to femtosecond flap LASIK now, and there are different machines. It's very precise. Risk of getting free cap, buttonholes, free flap, almost none. So complication rate goes significantly down with all femtosecond laser machines. So just to show one video of flap LASIK. So this is done on the Visumax machine. So lifting the microkeratome flap is entirely different than the femtosecond flap. So microkeratome flap is a free flap. You can lift with any blunt instrument. There is no adhesions. But in femto flaps, you have to be very careful. There are some uncut areas also sometimes. So you have to be very careful. Go in a multiple step. Don't go in a single step. Unless you are a very confident or very experienced surgeon, go in a multiple or 2 or 3 step lifting, so that there won't be any problem in the flap. So coming to eximers, excimer is derived from the contraction of excited dimer, and the goal of excimer is to reshape the cornea. So mostly patients ask you what you will do in laser. So we have to explain that we are going to reshape the cornea so that light focus on the correct point on the retina. So these are the different laser-based systems which are available in the market, and almost all the machines have shifted on the flying spot laser, which is the most accurate and quickest laser now. And all machines have the iris tracking system, because patients move well when you're doing laser. So with the iris tracker, there won't be any effect on the ablation. So coming to the complications, there's some complications, although not very regular, like incomplete or complete or decentered flap, buttonholes, epithelial defect. So we have to be very careful in patients in which you develop epithelial defects, because if epithelial defect occurs during surgery, risk of epithelial ingrowth is very high. So it's always better to remove the entire epithelium in that area, put the BCL so that it can heal in totality. And then this is a scan showing post-LASIK ectasia here. So coming to the surface ablation was a very popular procedure in 90s. Then it goes down because of the post-PRK haze, and from last 1 decade again it is coming up very nicely with mitomycin C and with the advanced laser system. Now the haze incidents are extremely less, and recovery is very quick. Patient needs at least 3 to 4 days to recover, but after 4 days patient do very well, and complete recovery mostly take 1 month. So one more thing which we should be very cautious is to avoid any kind of infection in post-operative period, because I've seen many PRK patients developing infection in first week time, because there is no epithelium. You have already done the laser, cornea is compromised, and BCL is there, and you start steroid along with that. So I have changed, because I have seen many complications in my fellowship. So I've changed my regime of managing post-PRK patients. What I do, I don't start steroid in first 3-4 days until the healing is complete. Remove the BCL, then start the steroid. Patient will be in little pain for first 3-4 days, but you are sure that he is safe. He is not going to develop infection. Although recovery delays little bit, but safety is there. So I chose safety over the speed of recovery. So coming to the advantages of surface ablation, comparable visual outcomes, lower, not lower, it's no flap concerns, almost very less risk of ectasia, because you are ablating very minimal amount, no flap issues, so ectasia risks are not there. Quicker, cheaper surgery. You don't need microkeratome, you don't need femtolaser, you just need ablation, just excimer machine. And no learning curve also, it's very easy. And with the trans PRK, you don't need to touch the patient also, just put the speculum and machine will do the job. So almost no learning curve. Complication or concerns with PRK, discomfort initially, Risk of infection, as I told, some patient has delayed epithelial healing. So this is also a concern with some patient, because patient keeps on complaining with the photophobia, glare in post-operative period. So mitomycin help these issues, but not fully. Many patients complain. So it's better if patient is complaining, you can again put BCL, because patient has already recovered the initial epithelial defects. So you can put BCL in 2 weeks time, start on the steroid, then patient symptomatically free and recovers nicely. Then late complication, some patients also reported some loss of vision because of haze in the center. Then late complication, some patients also has diffuse haze or cholestasia. There is a tendency in some patients that they will develop more haze, like patient who have significant scar formation tendency or keloid tendency. So we have to take the history properly, whether they have these issues preoperatively or not. All patients who have collagen vascular disorders and facial rashes, significant inflammation on the lid. So in those patients, we have to be very careful, because they can develop slightly more haze. Then refractive complications, with PRK, if you're treating very high number, chances of regression is always there. So we have to be very careful. So it's always better to be slightly to the over treatment, so that if it regress 0.5 or 0.25, patient doesn't face any problem. And this is a publication with PRK haze, which tells with mitomycin C, the risk of haze goes significantly down. Coming to the last procedure, the KLX is a new term for all of us. So initially it was popular as a SMILE procedure with the Visumax machine. And with the newer machines, now JCRS has decided that they have merged all the machines, because it's Clear, Silk, SMILE, although all are same only. So JCRS has decided that they will give the nomenclature of KLX. And KLX is a keratorefractive lenticle extraction procedure. So all procedures are called KLX now. And these are the 4 platforms which are available in the market, which does almost exactly the same thing. Although the branding is different, the cost is different. And one is from Zeiss, that is SMILE, we all know. The next is a Clear from Zimmer. It stands for Corneal Lenticle Extraction and Advanced Refractive Correction. The third one is Silk from J&J. It is called Smooth Incision Lenticular Keratomiliosis. And the last one is from Schwind, which is called Small Incision Guided Human Cornea Treatment. So just a small video of SMILE. So it usually takes 20 seconds to do a SMILE procedure on Visumax 500, and the newer machine takes 9 seconds only to do this procedure. Advantage of this procedure is the suction is very in a normal human range. So only soft docking, it does soft docking, no subconjunctival hemorrhage. And because this is a very old machine now, almost more than 10 years, so the technology has matured with the Visumax. So you get almost consistent result in all patients. I have not retreated any patient in last 5 years. All patients are doing well, no regression noted, just 3 suction loss in last 5 years. And these patients usually do well. Next day, patient usually has 6/6 or 6/6 partial vision. It takes 4 to 5 days or maximum 1 week time when patient sees 6/6 nicely and without complaints. Learning curve is not too much. If you're a cornea surgeon, there is no learning curve. You're not a cornea surgeon, it will take 4 or 5 cases to learn this procedure. And coming to the last part, when not to do refractive surgery, the red flags, younger age patient, if patient is just completed 18th birthday, because we have seen many patients that today is his 18th birthday, just remove his specs. So always counsel these patients to wait for some more time, because with rapid increase of myopia, there is chances that myopia can progress. He should ideally wait for 1 year or 2 year. High myopia patients progresses more than the low myopia patient. So if patient is coming with very high myopia, you have to tell patient that chances of progression in your case is slightly more than the patient who has a very low myopia. Again, the topographic pattern, if you find any signs of or any red flags on the topography, always defer cornea-based procedures. Very steep corneas, again, and thinner cornea, these 2 conditions always associated with keratoconus. So we have to be very careful with these situations. Absolute contraindication, keratoconus, scissors reflex, very steep cornea of more than 47, suspicious topography. Pupil size. Pupil size is very important to have the good outcome without glare and halos. So large scotopic pupil rule out LASIK if the optical zone diameter is smaller than the pupil itself. So never do laser in these cases. The treatment zone should be at least as large as the scotopic pupil and never smaller than 6 millimeter. Thin corneas, although there is no clear guidelines when you should do up to what thickness, people are doing 480 also, 470 also for mild refractive error, but it's always better to be safe than sorry. So 500 or 490 is should be the cutoff in which you should touch the cornea. And the other important factor is, again, the RSB thing. You have to calculate how much you're treating, how much you're saving. If you're saving 300, so you're in safe zone, you can treat. If you're treating like 3 diopter or 4 diopter in 490 and residual is 300, you're pretty safe. So you can go for the procedures. Absolute contraindication, pregnancy, lactation, nursing. In these patients, we should not do surgeries. Again, the rashes, malar rash, and autoimmune disorders, because they have a tendency of scar formation and delayed healing. So we should avoid surgery in these cases. Also, any type of viral keratitis, old viral scars, because there are reports that laser has reactivated these infections. So we should avoid doing surgery. And the most important in today's world is a dry eye. So many of these patients are using contact lenses and suffering from dry eye, although they are not aware of that. So we should do dry eye workup. At least TBUT and Shermer's is a must for all refractive cases. And last, with the patient, if they are taking IC241, we should ask them to consult their skin specialist, shift to the alternate drugs, stop it at least for 2 months or 3 months, then go for the laser-based procedures. And we often miss this situation. That's epithelial dystrophy or recurrent erosions. Many patients have old history of injury, and the scar is nicely healed, so we don't look at carefully. But if you take the history of trauma or erosion, then they will tell that sometimes they have pain or watering. So never do LASIK procedures in these cases, because the healing will be a problem. All contact lens users usually have vascularization, limbal vascularization. So in these cases, discontinue the lenses for a month, start on FM and lubricant. Once these vessels settle down, this cornea becomes, conjunctiva becomes quiet, then go for the laser procedures. So in conclusion, proper history taking and examination can help in correct decision making. Corneal tomography is an invaluable tool before planning refractive surgery. Never do refractive without tomography. No laser-based refractive surgery should be done without this. And all patients are not fit for refractive surgery. Choose judiciously. Thank you. Thank you.
Any questions from the house?
Yeah. So my post-op regime is, so from day one, I start patients on antibiotic with some anesthesia added in that, xylocaine, so that patient will have less pain. And along with that, lubricant, Nevernac, and cyclosporin, so that it will take care of inflammation. Nevernac and cyclosporin will take care of his inflammation. And on 4th day, I remove BCL. I stop everything except lubricant and cyclosporin, and I add FML in that. FML 4 times for 1 month. After 1 month, I call patients. If patients are doing fine, 6/6 vision, no problem, stop FML. If they complain that sometimes they have a problem, you can taper it, make it 2 times for 1 week, 1 time for 1 week, and then after 2 weeks, you can stop. And the restasis, I usually give for 6 weeks. If patient shows some signs of inflammation or some minor complaint, we can extend it for 3 months. So this is the post-op regime. But with not using FML in first 4 days is a very peaceful thing for surgeon, because you're sure that there won't be any infection. So that's because I have treated many patients that come from periphery. They've done the PRK, then full cornea is melted, bilateral melts. So that's a problem.
How much ablation or epithelium you are doing manually or by
So both the method, if you don't have the machine which has trans PRK, you can do the manual ablation, manual removal with the hockey stick knife. If you have a trans PRK machine, so the laser will do the entire job. And if you talk about the result, there is no difference in the result.
How do you decide by PTK how much epithelium?
So PTK,
50 microns,
so
55 micron, or
so it's very difficult to say. You have to see the color change on the cornea, because the newer machine like Schwint and Alcon, they have the trans PRK softwares. So if you put a software, the machine will decide how much the machine has to remove, and then it will start the ablation for the correction. But the machines which don't have the software, in those machines, either you can do epithelial mapping to know what is the thickness of the cornea. You can decide on that basis. Second thing, with experience, you know it will change the color. Once the epithelium is gone, the color will change, so that you can decide accordingly.
Sir, is there anything like below 2 diopters you do normal conventional PRK, and above 2 diopters you can go for trans PRK? Is it something?
As I told you, there is no difference in outcome. The result is same, whether you are removing with the laser or whether you're removing with the hockey stick knife. There is not a much difference.
So even if it is low
Yes,
power, you
yes.
go ahead with trans PRK.
No problem in that. No problem. Yes, always.
She is also using isoretinin. So then in that case, what you will do? You have to do C3R for that patient.
Okay, so you have to stop the isotretinoin if you are doing any laser-based procedures, because it will increase the scarring, post-operative scarring. So there are now newer drugs that skin specialists shift them temporarily. Okay, once the cross-linking is healed, after 3 months they can go back to isotretinoin. There is no problem.
So anyways, in C3R we are inducing scarring, na, sir. We want scarring to happen in.
No. So isotretinoin, along with scarring, dryness is the main issue actually with isotretinoin.
Okay.
We stop isotretinoin because of the dryness, not primarily because of the scarring.
Also isotretinoin increases the progression of myopia and increases the size of the lens, causes shallowing of the anterior chamber, increase in the IOP. So there are many things which isotretinoin is doing. So the most important thing about this thing is that it increases the myopia also, a temporary increase. So you stop it, whatever myopia stabilizes, then you do. Otherwise, wait till, sometimes it can increase myopia by 5 diopters. That is what I have seen in my practice. So sometimes it is, very, very challenging thing once the patient is on that for whatever depression or they're using it for. So it's you have to be very sure that the effect is totally gone before you can touch the patient.
So after how many days you will take up for C3R?
First you have to, for C3R there is no urgency, because at least let the patient stabilize because this is antidepressant also. So you have to take the consultation with the psychiatrist also. For the patient, go back, because you are not the person who is prescribing it. Majority of time, the psychiatrist prescribes it. So you have to ask them.
Isoretinin mostly they will be prescribed by
skin
dermatologists. That is topiramate. What you were telling was topiramate.
Okay, sorry, I'm sorry for that. Yeah, I confused it.
And regarding testosterone inhibitors, some patients are using for hair transplant and all. Is there any need to stop before LASIK surgeries?
Finasteride and all.
Testosterone inhibitors.
No experience.
No experience about that. We need
Many
to- we need
patients,
to look
they
for
are
the literature.
they use hormone therapy, they are on, and for endometriosis and many other things, the young girls. So,
PCOD and all.
yeah, PCOD.
Yeah, so most of them
So,
are
but,
steroids only.
Yeah. So, but I have discussed with many LASIK surgeons. They say that they don't. They don't stop or they don't do anything. Because they are on hormone therapy, so whether
We are not doing in pregnancy and lactation mainly because of that, right?
because of that reason. But if we can stop for some time, they have recently started. then I stop the hormone. I take ask them to consult their gynecologist and then decide
So
if
is
they
there
can
any
stop.
like limit, like we are stopping isotretinoin 2 months for 2 months? Is there something like that, or 1 week or something else?
1 week won't help.
1 month, I think. 1 month is
at least.
something we
Because
should.
most of these drugs are steroids only.
Yeah, yeah, yeah.
So we have to
Because after lactation also, we ask them that once they have started, so they have to wait for 1 to 2 months or 3 months, then we can do LASIK. Otherwise, we don't. Doctor,